Hello, everyone. Welcome to Cracking Addiction. My name's Dr. Ferghal Armstrong, and once again, we have with us the great and erudite Dr. Richard Bradlow. So, Rich, I thought we'd talk today about the urine drug screen, to do or not to do. What's your view on it? Where does it have a role in modern SPS clinics?
To do or not to do, that is the question. Whether it is nobler in our minds to suffer the slings of arrows of outrageous fortune, or take arms against them and by opposing in them. Well, Fergal,
And
we
by
said before
opposing,
we
do a urine drug screen. By
yeah
opposing, piss in the pot.
before we were going to record this, I said I would play the foil here, but I don't know if I can do it. But for the sake of this podcast, I think urine drug screens are terrible, and I don't think we should do them.
Why do you say that? Why should you not do urine drug screens?
Well, the arguments I hear against them is that most of the time, when you do studies, most of the time, and I would say clinically, most of the time, you already know the answer because people are honest with me. And I'm very, very rarely does a urine drug screen not have what the patient or client has told me will be in it. In fact, the only time I really encounter that would be when someone says they can't provide it. Then that implies to me that it's going to be positive, and that to me is an answer enough. The other thing would be, is it damaging rapport? Is it, acting like we don't trust the clients that see us or the patients that see us? And the other objection I think that is commonly raised is that it's punitive. It's oh, you don't give me a urine drug screen, or I'll take away your takeaways.
So there's lots of arguments to not do it. It affects the therapeutic relationship. It causes stigma. Why are urine drug screens then even talked about? Why do they say that you should be doing in stable patients, for instance, that you should be doing 4 a year? Why do the guidelines say, oh, they need to be done before you start treatment, and in the early stages of treatment they need to be done fairly frequently? What's the whole point of that?
So I think, to me, and I think a good way of couching this is that I'm not sure they are necessary if someone is on long-acting injectable buprenorphine, nor am I sure they are necessary if someone doesn't have any takeaway doses. But when we are giving takeaway doses of an addictive medication that, if diverted, and we know these medications are diverted often, would kill us.
Yes.
If I had half the dose of any methadone dose that I have prescribed in my entire life, I would die. Half, a quarter. It happens, right? And if I prescribe a medication that is then, one of the takeaways is sold, or diverted is what we call it, and it's sold to a teenager, and that teenager has a sip and dies, which they will, then
Which
the
they
coroner will
have
say,
done.
they have done and they will do in the future.
Yeah.
The coroner will say, Dr. Bradlow, why did you give this person takeaways? And I will say, well, I did regular UDSs, and it's, the whole, we are constantly playing off between takeaways and, and retention. It's diversion versus retention. The more takeaways we get, the more retention we'll get, which is great because people in treatment are going to have better outcomes. The less takeaways, but the more takeaways we get, the more diversion we're going to get. It's inevitable, right? And to me, it is. I don't want to say it's defensive because of what the coroner says. It's how do I prevent harm? And I want to prevent harm by having as many people on the program as possible, and I want to prevent harm by stopping people from selling the substance.
Exactly. So there has to be an acknowledgement that methadone, medical grade methadone, and medical grade Suboxone is freely available on the streets of Melbourne. And the only way that it is freely available is because somebody somewhere who's been prescribed it has got a takeaway and has sold it. There's no arguing with that point. So I like what you say about the role of urine drug screens being questionable when we're talking about long-acting injectable buprenorphine and on daily pickup. So really, is the role of the urine drug screen simply to make an assessment of the suitability for takeaway doses, or does it have another role? Should we be doing it in other circumstances?
I think it has lesser roles. It can be a conversation starter in terms of other assessments, but in terms of, do you need treatment for other? Should we be talking about the other substance uses? Do you have a use? Is But to me, it's about takeaways, and it's about, are you on an adequate dose? I see you're continuing to use heroin, but to me, it is
Mm,
entirely about takeaways.
yeah. So, what about the idea that you need a couple of positive urine drug screens before you initiate opioid agonist therapy?
Yeah, I think you need one. A couple seems a bit, because again, so I mean, I think there's a fantastic case when we were working at the same clinic, when you're in a public clinic, and there's obviously there's registrars that rotate every year or 6 months. And I was looking back, I was doing a file review on one of our patients, and I noticed that the registrar that had worked before me had not been checking the UDSs, and actually they'd been consistently negative for 6 months, even though this patient had been on high dose diazepam prescribed by another doctor, high dose amphetamines prescribed by another doctor, so high dose dexamphetamine, and we'd been prescribing Suboxone. And this patient had been absolutely abstinent from all these medications in all of the UDSs until this registrar, in his wisdom, started this patient on an LARB. So, so I can assume that this patient is diverting all of the medications, and I wrote to the other prescriber explaining this. And then they were diverting the Suboxone, but then we got them dependent on on Suboxone, on buprenorphine, by starting
On
LARB,
buprenorphine.
which is a terrible outcome. And then when I talked to the patient about it, they said that they couldn't provide they were outraged, and they couldn't provide a UDS that month, but they would provide it the next month, and the next month they sure enough had a positive UDS, because I'm sure they remembered to take the diazepam and the dexamphetamine before. And when I questioned, well, why are you getting that? Oh, well, I'm not using the diazepam. I was like, well, you're getting it dispensed every 2 weeks in a manner that's suggesting it's filling my cupboards. It's an odd thing to go. Anyway, so I think there is, I think if we start someone on methadone who's not addicted to heroin, we're causing harm. Opioid agonist therapy is harm reduction. It's not, and if you aren't already addicted to an opioid, it's not harm reduction. It's harm addition. So I do think
Yes,
it's
harm
important, but I don't
causation.
know if I'd get more than one, because you're playing off time to treatment, and
Mm.
the benefit of getting someone on treatment. And I think putting up barriers and jumping on windows of motivation, I think you want to be pretty quick about that.
Yeah, I mean, when we think about patients who are stable, I mean, I still think that we should be doing them even on stable patients. I think we should be doing them on everyone. Everyone who's on opioid agonist therapy should be. We should be having urine drug screens. I know that we don't do them, or certainly I don't do them as much as I should. I advocate for.
The clinic you work in does them on every single patient every single month.
Yeah, but I sometimes forget to order them. But I always think I
Sure.
wish I had a urine drug screen.
Yeah.
I think for two reasons. I think everyone should. It should be part of the routine care for everyone, because first of all, if it's part of the routine care for everyone, then it does reduce the stigma. You're not singling anybody out.
Exactly.
But there are two situations that I want to bring up. The situation first is I deserve takeaways because I'm not using heroin, even though I'm using methamphetamine. I'm not using heroin, and the Suboxone or the methadone you're giving me is controlling my heroin use disorder. And here's my urine drug screen to prove that I'm not using heroin, but I am on amphetamines, and that's showing up positive for amphetamines. I personally, well, before I tell you what I think, what do you think?
I think it's very dependent on the patient. Um, to me, it's not an absolute no. So why like use? Why do we not give takeaways to someone who's using? Well, it's chaos, right? That's what we're worried about. We're worried about
Mm,
a chaotic lifestyle, and so obviously methamphetamine use, chaotic lifestyle. But I actually think heroin use, in the context of is not an absolute contraindication to some takeaways. No takeaways is a very strict um,
well,
prescription.
it is very strict, but you're absolutely right to bring the point that a positive urine drug screen does not automatically mandate the removal of all takeaway doses, according to the Victorian guidelines. It's not an absolute contraindication. But your takeaway doses are mandated for people who are stable. And, I would argue that if you're not using heroin, but you're using methamphetamine, then I don't believe that you are stable. And so for
Look,
that
actually,
reason, I would
on
be
your guidelines,
reluctant.
a colleague at work pointed out the other day that the guidelines don't state explicitly you have to get UDSs. They recommend it, but they don't state explicitly you have to.
Yeah, you don't have to do it explicitly. Yeah. So I think stability is one of these nebulous terms that can be interpreted in various ways, but I choose to interpret it: if you're using any illicit drug, then you're not stable. But I accept that there are others that don't agree with me. Um, but people who do appear stable can also fall foul of relapse, and they don't necessarily know what's going on. And so I'm going to tell you this. This actually happened to a colleague of mine. This patient was actually working as a social worker, and he was stable on 100 milligrams of methadone a day for months, years. And he eventually got up to 6 takeaways of methadone a week. So he would go into the chemist one day a week and get his entire dose of methadone. And then, he hadn't done a urine drug screen in over a year. And then the doctor prescribing said, oh, let's do a urine drug screen. And so it came up positive with heroin. So the patient was brought in to have a chat. He said, yes, I'm using heroin. So the doctor then said, well, you're not stable. I'm going to take away your takeaways. So the patient had to go to the chemist every day to dispense his methadone. And 3 days later, he was dead. So in that situation, I think what had happened was that he was actually selling his methadone and only taking maybe a half to a quarter of his methadone dose. And then all of a sudden had to suddenly go back to taking all of his dose supervised. And of course he wasn't tolerant and he died. So when you're moving someone from, a pile of takeaways to no takeaways, you also have to consider the potential loss of tolerance involved. And you have to be cognizant of the risks of causing a iatrogenic overdose. But then again, I had another patient who this happened to me now. I had a patient that I was giving Suboxone to regularly, and I just happened to do a random urine drug screen, and it was positive for opioids. And I thought, what's going on? And he said, yes, he'd shot up. So I thought, well, look, I'll just do a liver test just to see what's going on. And I diagnosed him with new onset hepatitis C, because his liver was a little bit deranged. I said, your liver's usually perfect. What's going on? And then, of course, one test led to another. But I would not have picked up that hepatitis C had I not done that urine drug screen.
Look, I think the answer for all the it damages rapport is it's never damaged rapport with me. And I think if we are friendly with patients, if we are honest with patients, if we maintain appropriate boundaries and we treat them with respect, then doing a test like a urine drug screen that is within safe practice guidelines shouldn't damage rapport.
The question is, what do you do with a positive urine drug screen?
It depends on the patient. It depends on the situation at hand, as you've discussed.
Would you take away all takeaways?
In some patients, I have taken away all takeaways. In others, I've said, I'm going to drop it. No, that's not true. No, if it's positive, if they're willing to give the urine drug screen, I don't necessarily take all takeaways away. If they give it and it's positive, I might. It depends on the chaos of around. We talk a lot about it in addiction. It's not just about the physical symptoms. It's about the effect on the life. It depends on my assessment of the chaos of their life.
Well, on that sweet note, I just really appreciate the forthright decisiveness with which you extol the virtues of urine drug screens. On that sweet note, Dr. Bradlow, we're going to have to call it. That's all for today, folks. My name's Dr. Ferghal Armstrong, and this has been Cracking Addiction.